Now, this next session, the paediatric session, is neurorehabilitation, but there's going to be an emphasis on non-accidental brain injuries, which is clearly quite a complex practice space. And there may be people in the room who've had some lived experience around some of these issues. And I just want to say that recognise that the speakers are coming from a place of deep concern, deep compassion, and deep care. So if there's anything that's said today that is difficult for you, feel free to come and speak to me at the end. I'll kind of hang around if there's anything that's kind of troubled you from any of the content. So that said, we have a fantastic panel. Two of my local colleagues, and we're going to start with Marie Spiers, who's the clinical lead for the West of Scotland Major Trauma Centre, and also has important roles with the national group looking at major trauma. And Marie's going to present some data about all admissions in the last, I think, 5 or 7 years, in the middle, looking at all causes of admission to major trauma centres in Scotland. So thank you, Marie.
Right, just lower this mic a little bit, quite a bit. Okay, good afternoon everybody. Thank you so much for the invite and for the introduction, Liam. And again, thank you to the organisers for asking me to come along to speak. I'm always really delighted to see that Paediatric makes it onto these meetings. I think it's really important that we don't forget about the children, and actually that has been a theme through a lot of the talks that have happened today. So as somebody who only works with children, I'm really, really delighted to see that. So, by trade, I'm a paediatric emergency medicine consultant here in Glasgow, and I have a couple of roles. So today I'm here representing the Scottish Trauma Audit Group. I'm the paediatric lead representative for that group, but I also have roles in the Scottish Trauma Network. And I will talk about both throughout the course of this talk, and just give you a little bit of oversight of both of those. So I was sitting, as most of you were, listening to the talks earlier on with real interest, but I was listening to Michael Canty's talk and thinking, he's stolen my slides. Where's he got that information for? But actually, there is a lot of overlap with some of the things that Michael said, but I think that's really good because it proves if more than one person's saying it, then it must be true. So what I'm here to talk about today is the Scottish Trauma Audit Group Paediatric Report. So this report specifically looks at under 16 trauma admissions in Scotland. Okay, this is a really important document. It looks at patient journeys across 2018 to 2023 inclusive. Now, some of you may be aware of STAG, some not. The adult STAG audit has been going for a number of years. And as always, paediatrics just sort of lags behind a little bit. So we only started doing pilot data in 2016. So this report really is the first of the data of its kind in Scotland. From 2018, we had mandatory data from all of the sites across Scotland. And so what I'm going to present is some of the findings across that first 6 years worth of data. You can tell how long it was to pull the report together. Initially, it was going to be a 5-year report. By the time we'd finished, it was actually 6 years. So, and really the purpose of this report, as I've said, we've not been able to do this before because we haven't had the data, is really to provide that evidence-based illustration of what trauma looks like in children in Scotland, what the epidemiology is, how it presents, and some touching on some of the management. This report was first published in the summer of last year, and it follows the journey of over 1,300 cases of children and young people under the age of 16. Specifically of interest to this group, we looked at a subset analysis of the traumatic brain injuries, which were roughly a third of those cases, 408 children in total. And actually this work was presented at the International Paediatric Brain Injury Society conference that was more or less to the day this time last year. So really just to set the scene with STAG, we know that the data I'm going to present to you really is the tip of the iceberg. STAG have got inclusion criteria. You have to meet them to come into the audit. One of those is that you have injuries which require an intensive care admission, that you're in hospital for 3 days where your day of admission is day 0, so technically really 4 days of an admission, or that you die in hospital from your injuries. We know that, like I say, this is the tip of the iceberg. This diagram is representing data from 2022. So we had roughly 200 children go into the STAG audit, but we know that the major trauma service, there's about a third, 3 times more patients actually get benefit from that major trauma service, even though they don't make it into the STAG audit. And Public Health Scotland produce an unintentional injuries report every year. We know that unintentional injuries cause around about 6,000 ED attendances a year. So we really are looking at the tip of the iceberg. The other thing to say is that our Scottish Trauma Network really is in its infancy, and we've utilised this data really to help drive services, think about where the gaps are. And I'm going to give you a feel of how we're using the data to do that. So I'm just going to take a second just to talk about the Scottish Trauma Networks. So trauma networks are not something that's new. They've been modelled in other places, other countries across the world, and have been shown to have proven benefit to trauma patients with improved outcomes. As I say, our network is in its infancy, with the remainder of the network going live in 2021. And I can tell you, trying to get a trauma network to go live in a global pandemic was no small feat, I can tell you that. In terms of the network itself, we are incredibly lucky to have Scotland to deal with and all of its beautiful geography, but it doesn't come without its issues. Obviously, you can see, looking at the map there's lots of remote and rural areas, and trying to make sure that there was an equity of access to trauma care across all of those remote and rural areas really is difficult. From an adult perspective, there are 4 major trauma centres. They are in Aberdeen, Dundee, Edinburgh and Glasgow, and for paediatrics there are 3, that being Aberdeen, Edinburgh and ourselves here in the West. But it's also important to note that some national services for paediatrics are thrown into the mix, because there are only 2 paediatric intensive care units within Scotland, and they are in the Central Belt in Glasgow and also in the South East in Edinburgh. So that's just to give you a flavour of the network and how it's come to be. In terms of looking at the data, so looking at all injuries across Scotland across that 6 years in that under 16 group, actually our numbers year on year are relatively consistent. You can see that sort of 5th graph there is the whole of Scotland, and the numbers don't fluctuate too much. The other thing that you can take here is that there's clearly very much higher volume areas that look after children, not unexpectedly so, sort of focused around the Central Belt, particularly in the South East and ourselves in the West, with the West contributing half of the paediatric STAG cases every year. So looking at sort of the nuts and bolts, getting into what the data is telling us. So there are lots of reports like this that exist. We have colleagues down across the UK, colleagues in Ireland that have produced very similar reports to this, and it's good again to see that there is some consistency in that. The question then is what we do with that data. But you might not be, so that picture on the left-hand side there might not be unfamiliar to you, and we see that we have seen that classical bimodal presentation of injuries, really focusing in that sort of 0 to 2 group. And then again, when we get into that 12 to 15 year age group where, you know, they start to develop more risk-taking behaviours, they haven't quite developed the common sense and consequence knowledge that they need, and we see a sort of resurgence of trauma happening in that group. When we look at all injuries, we see major trauma accounting for 18.6 of the 0 to 2s, much higher number as we get into that sort of 12 to 15. Again, their sort of riskier behaviour that we're seeing from them. So that's not a surprise. Those of you in the audience like me that are privileged enough to be the keeper of a boy will not be surprised to hear that they are our clientele, unfortunately. And that is true when we look at specifically just major trauma as well. But when we came to look at the traumatic brain injuries, really we saw a very different pattern. And I think it's really a stark contrast that you see on that right-hand graph there with that huge spike of children under the age of 1 sustaining injuries. So we see that significant peak in that age group, which is different to the all-injury cohort. And the under 1 group account for 27% of all of the traumatic brain injuries that we saw in this cohort. We're also much more likely to see major trauma in that group and less of a difference with the TBI group when you get to sort of 12 and 15-year-olds. So they're not necessarily sustaining more significant brain injuries than the younger children. But we still see that preponderance of boys. And again, that's true when we look at major trauma. And just for clarity here, when I'm talking about major trauma from a TBI perspective, what I'm really alluding to is an injury severity score of more than 15, particularly looking at an abbreviated injury score of the head region of above 2. So that under 1 group really sort of came into very sharp focus when we looked at this data, really thinking about, well, why should that be the case, that the under 1s really seem to be at a significant risk of head injuries? As I've said, they account for 27% of all of the head injuries that we saw. But actually when we broke that sort of 12 months and under down, what we actually saw was by far and away the majority of the injuries that we see are happening in children that are under 6 months old. Why is that important? Well, these children are not mobile. They're not able to independently move. There really should be no real reason for these children to be sustaining significant head injuries, and they are significant head injuries, with 77.8% of all TBI-associated major trauma in the under ones happening in that younger age group. So you're more likely to have a traumatic brain injury under 6 months, and it's more likely for it to be severe. Why is that? This is really a question that I think is really important for the network moving forwards. But it also allows us to think, and colleagues this morning have spoken about, the sort of importance of prevention, because there's that primary injury that we can't really do anything about, and then some of the secondary things that we potentially can. But this data gives us an opportunity to really look at whether we can generate some targeted accident prevention, specifically looking at this really young age group. So thinking about mechanism of injury, again, we see that changing over time with age groups, with falls being the predominant mechanism of injury for children under the age of 2, with that accounting for about just over a third of patients, but very few of them being motor vehicle accidents. And again, we see almost the reverse of that when you get to the sort of older adolescents that maybe are becoming a little bit more rebellious, shall we say. And we're sort of seeing motor vehicle accidents there significantly higher. When I'm talking about motor vehicle accidents here, I think it was said in a talk earlier this morning, really we're talking about pedestrian versus car RTCs, or pedestrian versus cyclists. We are definitely seeing a huge increase in the number of children that we're seeing having injuries from e-scooters and e-bikes. And I know Michael mentioned that in his talk. It really is a significant problem that we are seeing. At the moment, STAG, at the time of this report, I should say, STAG didn't collect that data, but one of the outcomes from this report, we are now absolutely collecting that data on e-scooters and e-bikes, purely because that just increases the energy transfer, the mechanism of injury, because they're just going much faster. And again, this gives us an opportunity to think about targeted accident prevention strategies that we maybe need to think differently, as we always do, about the small babies versus the older children, but really targeting accident prevention models, looking at those different groups. Now, I am aware, and I'm very sorry, that there are some people in this room that have heard this talk, actually some people more than once. I'm really sorry about that. So if you ever have heard me talk on this subject, you will absolutely have seen this graph, because this is one of my favourite diagrams ever, because it confirms my long-held belief that we should not let children have summer school holidays. They should be kept in school, because they are much safer in school. They're not having the injuries that we see at other times of the year. Really, just to point out a really stark difference that we notice between the all injuries group and the TBIs in this is, if you look at that sort of red line with the really helpful yellow ring around it, that coincides exactly with the first lockdown of the pandemic. And you can see that we saw a significant decrease in all injuries because children weren't really out and about and playing. But we didn't see that happening with the TBIs. And again, that is, we presume, and this is a presumption, that it's because the majority of those are small babies that were already in the house. You know, actually the circumstances for those injured children didn't change. Again, thinking about how we use the data, it's one thing to collect it, but another about how actually are we physically using this data and what changes are we making, what we're thinking about using this data. And this is really important and quite unique to paediatrics. And this is about how children access healthcare and how children and their families access healthcare in the context of an injury. What we know is, and what the data showed us, is that around about a quarter of all of our major trauma, whether that be the TBI group or the all injuries group, will just pitch up to the front door. Okay, they're portable, parents panic, they will put them in the back of the car and they will go to the nearest facility. And that the parents don't know / don't care whether you're a major trauma centre or whether you're a remote and rural GP. They will go to the nearest place where they think they can get help for their child. What does that mean for us? Well, sorry, just to sort of reiterate that, it really is a paediatric issue, because when we looked at the numbers for adults, the numbers that over the same period of time, only 8.7% of their major trauma is presenting ad hoc without a pre-alert. So when they come in by ambulance, we get a pre-alert, we have a team ready to greet them. I can tell you from experience, it's a bicycle clips moment when they just run in with a child that's been significantly injured and you have to respond to that. So one of the things that has become apparent is that actually in setting up the Scottish Trauma Network and having these different designations of hospitals, become very apparent that actually what we need to do is keep the capabilities of resuscitating severely injured children across each of those designations of hospitals. And as you can see, the numbers are relatively small. Even across 6 years, we're talking about 1,300 children. You know, how do we do that? How do we keep those skills set when you might only see one every couple of years? But it's really important that we do that. Another fallout from that is that a significant number of children, more than a third of children, require a secondary transfer for definitive care at the major trauma centre. And I think sort of the ethos of the trauma network was to get the right patient at the right place at the right time. So secondary transfers felt like a failure, whereas actually what we've come to learn is that it's an integral part of the paediatric pathway, that we need to make sure that these secondary transfers are going to happen, and how do we best protect them. And we've used our national retrieval team to do that, paediatric retrieval team Scottsdale, where the teams looking after the children will phone our retrieval team and have advice about how to manage and optimise the child pre-transfer and the best and safest way for them to be transferred to the major trauma centre. And you know, they're not straightforward transfers, with about just under 70% of them being done for specialist neurosurgical inputs. So they're not, you know, they're slightly hair and scarum transfers that we're talking about doing. So moving on, what we wanted to do was sort of look at population-based health, and one of the things we looked at was drugs and alcohol. That might seem a bit strange to talk about in a paediatric talk, but obviously we have that older age group that are maybe experimenting with drugs and alcohol for the first time, or maybe not for the first time, but also this included cases where the parent or carer or the responsible adult had taken drugs or alcohol at the time of the incident. And what we see when we looked at all injuries, thankfully, is that drugs and alcohol are very rarely involved, but when they are, we're more likely to see significant injuries and see major trauma. When we look at the TBI group, again, the numbers are quite small, but we definitely see more drugs and alcohol involved in the TBI group than of all injury group, and again, much more likely to see significant trauma when that is present. So we've talked about non-accidental injury, has been touched on in a couple of the talks today, and I think it's a really, really important topic. I think it's really important that we're open and we talk about it. It's not something that we like to think happens, but unfortunately it does. And I'm really interested to hear some of the things that Suzanne's maybe going to talk about after this in terms of strategies to sort of think about this. When we looked at our non-accidental injury rate, we found a proven non-accidental injury rate of 3.8% across the 6 years for all injuries. Now, let's just put that in context. This really is the tip of the iceberg. To get all the way through to be a proven case of non-accidental injury, there's a massive set of investigations and reviews that have to happen, and a significant chunk of them, while they're still maybe concerned that it's been a non-accidental injury, it cannot be proven. So we are talking about ones that have gone through that whole system and have been judged to have been a proven non-accidental injury. A third of them resulted in major trauma, almost exclusively under that under 2 group, to the point where non-accidental injury, unfortunately, was the cause of injury in 14.2% of the under 2s. However, when we look at the TBI group, this figure actually scared me quite a bit. We're looking at 8.6% proven non-accidental injury rate. Again, tip of the iceberg, 6.8%. Nearly 50% of them resulting in major trauma. Again, not surprisingly, almost exclusively in the under 2s, to the point where it accounts for more than 20% of injuries in the under 2s. That's really significant numbers. That shouldn't be happening. We need to look at ways of addressing this. And again, I'm looking forward to hearing about some of the methods that have been put in place. One of the talks earlier this morning, again, they pinched loads of my chat, was looking at social deprivation and injuries, and that was something we were interested to do. We actually saw very little difference between the all injuries group and the TBI group, so I've put the TBI data up there for you to see. We did see that there was that there seemed to be an association of significant injuries in the lower social economic groups of using the SIMD quintiles 1 and 2. However, interestingly, we saw different regions had very different profiles. Certainly the north of Scotland didn't seem to have as much social deprivation related injury profiles, whereas the west, as you might expect, did, but the west was much more in keeping with the sort of Scottish national average. So in terms of thinking about the network, one of the things that we need to show is that we can wash our own face and we're value for money. And the only way of being able to do that is to look at what some of the costs might be involved. Now, I'm not a health economist. I don't want to be a health economist. Thank you very much. But looking at what interventions were needed in this group, and actually what we saw is across the piece, the TBI group were much more likely to require interventions than the rest of the all injuries group. You're 3 times more likely to need to be intubated, nearly twice as likely to need an intensive care stay. And although fewer surgical procedures are done than you can see in the all injuries group, they're much more complex surgery in terms of the majority of them were neurosurgical, and by far and away the majority of them were for major trauma, versus the all injury group where, yes, they do a lot of operations, but a lot of those are relatively, she says never having done surgery ever in her life, relatively straightforward orthopaedic procedures that need to be done. Again, when we look at length of stay and discharge, you're more likely to be in hospital for longer with a traumatic brain injury. Which is important just to say that the cut-off there for 30 days, that's the cut-off that STAG used. So if you're in hospital at the 30-day mark, you're removed from the audit at that point in time. We are really lucky with our paediatric population that the majority of children go home. The majority of children go directly home from the hospital. But those in the TBI group, a bigger proportion of them actually required further admission for ongoing acute rehabilitation. And a much smaller but not insignificant number actually required to be discharged to another sort of either residential institutional care or psychiatric care. So again, these numbers are not small when you look at the sort of overall cost. So obviously the sort of black and white measure that everybody wants to talk about is mortality. As we've sort of shown across the piece today, that sort of black and white, survive or don't survive. There are other more nuanced ways of monitoring the effectiveness of a network, but certainly politically people want to know sort of mortality levels. And we saw an overall 2.9% mortality in the TBI cohort, which was higher than the all injuries group. Interestingly, in the TBI group, when you looked specifically just at major trauma, there were fewer deaths than when you looked at major trauma in the all injury group. But I think it's really important that we remember that all injury group does include the head injuries. So the majority of children that unfortunately succumbed to their injuries had some level of head injury associated with their injury profile. And just to sort of caveat this with STAG, don't collect patients who die at scene. So if they are not taken into the hospital, if they die before they reach hospital, they're not included. And also if it's an asphyxiation only mode of death, so hangings, drainage, chokings, they don't collate those either. They are collated elsewhere. So I know one of the big topics that has been touched on brilliantly by my colleagues across the course of the day is rehab. So we are looking at collecting rehab data. We collect patient-related outcome measures, and I think one of the really important things moving forward for the network and for STAG is looking at our rates of children returning to school, children returning to the same level of schooling and supported, or whether they need supported schooling, because there's also the element of what they're capable of doing, but also the element of whether parents can return to work or whether they then need to stop work to take up a full-time caring role. As I've said, our network is very young, and our STAG data is slightly older, but not by much. And obviously that sort of patient-related data takes time in terms of having that interval data. So we're not there with it yet, but watch this space. Hopefully the next time I'm presenting a 5-year report, we will have that data and be able to share it with you. So if you are interested in looking at the whole report, then please feel free. It's available on the Public Health Scotland website, and there's contact details there if you should want to ask any further questions. So thank you for listening to me try to make data sound interesting after lunch. I do appreciate that. Thank you very much.
Thank you, Marie. That was excellent, and of course, good quality epidemiology should allow us to plan services better. We do have time for a couple of questions. There is a plenary at the end, but does anyone have a question for Dr. Spiers just now? At the front, please. There's a question at the front.
Hello. A brain injury and a TBI. Is a TBI very serious, a life-threatening injury? What is the difference between a brain injury and a TBI?
So good question. So essentially they are the same things. The T bit stands for traumatic brain injury. So really it's just the subset of brain injuries that are caused specifically by trauma, as opposed to something like a stroke or a tumour, for example. So it's just that subset. In terms of the second part of the question, whether it's severe, again, we've sort of heard from lots of speakers that there's actually a spectrum. You know, you can have relatively mild brain injuries, and you can have the sort of spectrum all the way through to completely, well, you know, life-threatening and also life-altering. So there is that sort of spectrum. But the traumatic bit, the T is the traumatic bit, the traumatic mechanism.
That's a good question. Thanks for asking. Any more questions? No? Okay, well, great. Well, thanks again to Marie for getting us off to a start.